2 more minutes and then we could start.
Yes, yes. 5 past and we'll start. Assalamu alaikum, everyone. Good evening, and thank you for being with us tonight in our fifth PACES workshop session. And tonight we will be talking about communication skills and ethics. And we are very grateful for the presence of Dr. Mahmoud Montasser. He is a consultant nephrologist from Lincolnshire Hospitals. Thank you, Dr. Montasser, for being with us tonight. And you will be chairing the session. And you feel free to design the session the way you like. I'll be the surrogate as we have agreed on, and we will open the floor for open Q&A discussion, and we'll see how the session goes on. So the floor is yours, Dr. Montasser.
Thank you, Zainab. Thank you so much. It's my pleasure to be with you today, and we will discuss communication skills and ethics. 2 hours wouldn't be enough. However, we will try to focus on the most important bits and pieces that would guide you past this exam easily without any problems. I do understand that sometimes communication skills and ethics could be a major challenge and could be one of the difficulties. However, today we'll try to approach it in a nice and easy way so that it would be something straightforward, not causing you any problems. So I will start telling you about the new PACES and what's the main difference in the communication skills and ethics station. The new PACES should start from the 3rd diet this year, so by end of this year. So whoever is sitting the exam afterwards should follow the new PACES, and we will discuss that. After that, we'll discuss very quickly the importance of communication. And today I will provide you with a scheme for communication so that you could deal with each communication skill scenario as a problem solving, so that you could tackle that easily. I will also explain the different situations that you may face within this particular station, and then we will have some practice scenarios, and I would expect you guys to engage so that we will have 3 candidates, and Zainab will be a surrogate, try to challenge you and see how you would be able to deal with that. And then finally, we'll end this session by questions and answers regarding anything you think about or anything you like. So to start, this is the new PACES carousel that will start from the 3rd diet 2023. And the main difference, as you may see, that the communication now has been spread on 2 different, as you could see here, 2 different stations. Before the 2020 PACES or the 20...
Sorry to interrupt you, the slides are not moving if you're...
Not moving, okay.
Dr. Mahmoud, if you kindly put it as a full screen, and then so by any click the slide will move automatically.
It is a full screen already.
No, it is not full screen with us. It is on the
presentation mode. If you click on the presentation mode on the PowerPoint.
Okay, let me stop sharing first, and then I'll share it again.
Yes.
Yes,
now?
it is now. Yes.
Okay, thank you. So, so sorry for this interruption. So, as you could see, communication station now is mainly at station 1. There is 10 minutes for communication, and there's another 10 minutes for communication in station 4. And what makes it a little bit different in the new PACES that there won't be any kind of discussion with the examiners. So you will have the scenario 5 minutes before you go inside the station. You will be with your surrogate for 10 minutes. You'll deal with your scenario, and then you will leave the station. So there won't be any discussions like what used to happen in the past, like, for example, asking about the ethical issues and the legal issues, and what were the challenges in the station, and what do you think could have been done better, and all that stuff. That won't be available anymore in the new PACES. And based on that, just to remind you, with the main ethical and legal issues in terms of the communication skills, so there are 4 main ethical issues and 4 main legal issues. The first ethical issue is about autonomy, which is the patient's right to decide about treatment, to accept that or to decline treatment. However, patients could always they have their choice to decline treatment, but not to ask for treatment if it's not appropriate. The other point is beneficence, which means that we as physicians and as healthcare providers, we do our best to deliver what is good for the patients and not anything not in their best interest. Non-maleficence means that we won't be providing anything that could cause harm if we feel that the harm is more than benefit for the patient. That could include procedures, that could include medication, or whatever the medical service is. And finally, justice, in which the medical services and the healthcare providers will provide a service that is equal to everyone, regardless any thoughts, ideas, beliefs. Legal issues, mainly the first item is about capacity, and that's a very important matter, to be honest. Whether the patient is able to take decisions for himself or not, and what would be the situation if the patient is not able to take decision for himself or herself. For example, if patients are in coma or confused, or not in a state that could put them in a situation or in a position that they could take decisions, medical decisions for themselves. The other point is about confidentiality, in which the patient's data is pretty much confident for the patient, and it's only the patient who could declare what kind of data or any medical stuff regarding the patient. The third thing is about consents when it is valid, and that could be proxy consent, for example, if we're taking blood from a patient, for example, or it could be a written consent for major procedures or minor procedures. And finally, DVLA issues. These are legal issues that we should be aware of when we deal with any scenario that is relevant to that. And in terms of types of communication, it will be a little bit of a surprise to know that it's only about 8% of communication that is based on what is said in terms of words. But most of communication or the vibes that persons receive are from nonverbal communication, and that could be how the gestures of the body, or how you speak, how you try to clarify an idea, how you look to the patient, how you deal with facial expressions, and that's very important in communication. So I will give you an example for the power of word, and that would be a statement that I would mention at the moment, to speak about one of the most common diseases, for example, that I usually deal with in my profession, which is chronic kidney disease. So I will say this statement and you just tell me what do you feel about it. So a word without chronic kidney disease, I couldn't see that. So I couldn't see the first sentence.
I can tell you that, Mahmoud.
Yes, please.
A world without CKD is only a dream.
So yes, a world without chronic kidney disease is only a dream. And it's impossible to think that CKD will get the attention it deserves, because we know that hope is uncertain. It's why we refuse to believe the struggle will end. To fight the loss of function and fear of dialysis is beyond our grasp. And because life-changing discoveries are not our future. So what could you feel from this statement? Would anyone like to chip in and tell me what did you feel from this statement? Is it something optimistic, pessimistic? Yes. Adayan?
Yes, Doctor. Well, when you actually were mentioning it, it's very negative and it's impossible. It's making the CKD an impossible disease to be cured or to be managed, as people who say like dreams are like impossible. So it's very negative and it's very self-downing, I think.
I agree. Okay, I will read it in a different way, same words, but different maybe way of saying it, or different approach. But now we can do more to change our future, because life-changing discoveries are not beyond our grasp. To fight the loss of function and fear of dialysis, the struggle will end. It's why we refuse to believe hope is uncertain. And because we know that chronic kidney disease will get the attention it deserves, and it's impossible to think that a world without chronic kidney disease is just a dream. So what do you feel from the same words, maybe in different order? Well, I haven't changed anything within the words, within, you know, the sentences. Mahmoud. Did that make any difference? Adayan again. Did you feel that it's a little bit different?
So definitely it changed the meaning drastically. You can feel the difference, of course, quite noticeable.
So it could be the same words, but maybe different time, different place, different order, or different way of saying it. And that's why communication with human beings is not an easy thing. So for example, even in the era of social media and WhatsApp, or you could just text something that would be understood differently on the other end. But because there's no verbal cues, so it's very difficult to deliver your message. You know what I mean? And unfortunately, most of problems that do happen in hospitals between patients and care professionals generally, not just physicians. It's mainly about communication. Not because communication is not available or it's not happening. It could happen, but maybe it's not effective. And having effective communication means that I could deliver the message that I want, the way I want to you, so that you could receive it in the way that I'm satisfied with. So, and this is a statement for Stephen Hawking. He used to be a British physicist when he was describing communication. So he said for million years, mankind lived like the animals. Then something happened which unleashed the power of our imagination. We learned to talk and we learned to listen. Speech has allowed the communication of ideas, enabling human beings to work together to build the impossible. Mankind's greatest achievements had come about by talking, and its greatest failures by not talking. It doesn't have to be like this. Our greatest hopes could become reality in the future. With the technology at our disposal, the possibilities are unbounded. All we need to do is make sure we keep talking. Right, so let's get into business. So how could we figure out or invent some kind of a tool that makes the communication scenario something more or less different? So this is a general scheme that you could use for any kind of scenario. Any kind of scenario. Let me explain to you the scheme first, and then we could do some applied scenarios and see if that works or not. So initially, we have to start with a greeting. So you need to say hello, and then you will need to explain who are you and what is your role. And that's always present on the scenario that you will be given. And then you need to confirm the identity of the patient to make sure that you are speaking to the right person. Before getting to the main idea or the main task that you want to discuss, try to establish some kind of a rapport. And rapport means that try to break the ice between you and the patient. And try to do it in any appropriate or relevant way. So for example, you could ask the patient, have you been okay today? Is everything okay? Did you find parking okay today? If you find that you would not be able to do it in a relevant way, then don't do it. Just say, just go into your business and explain the aim of your appointment or your task. And that is the main issue that you will need to focus on. Please don't forget to fulfill your task. So if your task is explain, you have to explain. If your task is about a discussion or to feel what is going on and to pass a message to someone else, then that is your task. When you enter the station, just deal as if you're entering a dark room. So if you are entering the dark room, you'll just try to extend your arm and look for the light switch. And you need to do the same when you enter the station. So you need to explore some major issues that would help your task. Check understanding of your patient. Check if there's any concerns, ideas, thoughts. That's very important before just trying to explain something. So for example, in my profession, for example, if I want to explain a kidney biopsy to one of my patients, I'll start by have you ever heard about a procedure called the kidney biopsy? Could you imagine how we do that? Some of them may have had the procedure before with bad experiences, but won't tell you in the first appointment or just on speaking, especially if the patient is refusing or declining the procedure. So that's why it's really important to explore the patient understanding and what is around the situation, and try to do that cautiously without upsetting your patient in a way or another. And then number 7 is called, it's a specific point called my way, and that's my way in dealing with the different situations. And I will show you later what does that mean. And that will be related to the different situations that we will discuss in details. After that, you have to explore your patient's concern. What is the patient thinking about? What is the main thing that worries your patient? Because you may think that your patient is worried about something related to the disease, for example, but the patient is not really bothering about the disease. The patient is worrying about something else totally different. That could be a social issue, or a non-social issue, but not related to medical issues. So it's really important to probe the patient and know exactly what kind of concerns or what worries do your patient have. Always remember that you are not alone, and your role in this scenario or in this station, you are as an SHO in a huge hospital with loads of senior doctors, with specialist nurses, with other specialties, with lots of people that could help you. Don't try to do it a one-man show. Always involve others with you. And the other thing that you could use as an aid is any kind of supportive information that is relevant to the scenario. So if you're explaining a procedure, for example, you could give some supportive information from a relevant website, a medical website, guideline, leaflet, patient information, all of these do help. And then recap and check the understanding of your patient before ending the appointment. So that is a main scheme that you could apply to every single scenario, and it should work with every single scenario. Let's focus on my way to know what are the different situations. And these situations are pretty much fixed situations and they don't change. So we will discuss 5 main issues. So the first thing is explaining. Your task could be just explaining a disease or explaining a procedure or trying to clarify something for the patient. When you are explaining, don't use any medical terms. And if you used a medical term intentionally or non-intentionally, then explain it. So for example, I could say, we will need to put kind of a stent within your coronary artery, which means that we will put a very small plastic aid that would make your coronary, which is your heart blood vessel, to bypass the blockage within the coronary artery, within the blood vessel that supplies your heart. So if you, for any reason, found yourself by nature saying something that is jargon, try to explain it. Okay, and that could save the situation a little bit. And try to use all your tools. So if you are good doing non-verbal cues, do it. If you are good drawing, do it. If you want to use anything with your hands like this, for example, do it. Do whatever would help you do your task. If you're explaining a disease, then try to be systematic when explaining, starting from what does that mean? What is the etiology? What could the clinical signs and symptoms be? How do we usually investigate that? How do we usually treat that? And what is the outcome if you know about it? However, it's not expected from you in this specific station that you will give lots of medical information. It's about how you deal with a patient, or it's about how you try to deliver a message. And if there is a consent needed for a procedure, for example, then you will need to mention that. Not necessarily to say that I need to take a consent now, but you could say that I will come later to do some paperwork involving some kind of consenting before this procedure. After explaining, of course, all the risks of the procedure, why are we doing the procedure, and whether the benefits or the good outcomes from this procedure will be more than the risks that you mentioned. And it's always about what do you want your patient to do. So for example, if I want my patient to go for a kidney biopsy, for example, I would try to magnify the usefulness of this procedure and try to minimize the complications, not minimize it in a way to say that it won't happen. I will say it will happen, but at the same time, I could say, well, it's not uncommon to have some bleeding in your waterworks after this procedure. However, if that happens, it's usually self-limiting, which means that it stops by itself. And even if that doesn't happen, we have all facilities to deal with that on site. So the patient will feel, okay, fine. So even if complications do happen, then hopefully they will be able to manage. On the other hand, if the patient has got a high bleeding risk, that won't be the same way of saying it. So for example, I'd say, well, looking at your bloods, it seems that you have got a high risk of bleeding. And unfortunately, bleeding is one of the common complications that happen with this procedure. So I always describe it for patients, if you're doing a kidney biopsy, it's just like putting a needle in a bag of blood, because kidney is one of the organs that is really rich in blood supply. It receives around 25% of the heart blood in a minute. So the way I'm saying it, it's different. I didn't say anything that is wrong. I didn't fabricate anything, but it's about how you deliver it to the patient, how the patient receives it, so that it would help your task or help you doing what's in the patient's best interest. And that's the same thing that you could do, for example, when a patient is asking for some kind of treatment that you feel it won't be useful for him or for her. So you can always dilute this kind of treatment with other forms of treatment. So for example, if a patient that thinks dialysis, for example, would be one of the things, or a kidney transplant is something that he should have or she should have, while these kind of patients are not having the indication, or they have major contraindications to have a major operation, then I will try to dilute the kidney transplant with other modalities, like renal replacement therapy, for example, like conservative management. I'll try to focus on stabilizing the kidney function rather than dropping what we do when the kidney function drops. Not saying that it won't drop, but let's think about things when they come. That's how it works. That's how it works. So that is the first thing about explaining. So just to recap, so you'll need to explain a disease or a procedure. Try not to mention any jargon. Use all the tools available for you and what you feel you have high skills in. All items of disease or procedure should be explained in details. It's all about how you guide your patient to a procedure. If you want the patient to go for this procedure, or try to make him think again about it. And then it's finally, if there is a consent relevant for the station, then please don't forget to mention that. The second situation that you could face is a refusal situation, or patient is declining something. So refusal means that the doctor and the patient don't have the same agenda. So I need the patient, for example, to do something and the patient doesn't want to do that, which means that we are not in agreement. So the main rule is that we need to be in agreement, even if we agree not to agree, which means that, first of all, you'll need to explore why is the patient refusing or declining your advice. whether that is related to a patient that wants to leave hospital, for example, before completing treatment, patient refusing some kind of treatment. Most of the time, there is a hidden reason behind that. And to be perfectly honest, in real life, the patient won't tell you the exact reason unless he feels that you would, number one, listen, number two, appreciate, and number three, try to help. So if I feel, for example, that speaking to you is useless, or if we are challenging each other, I won't tell you my agenda. So almost always try to have your patient on your side so that both of you will have a common agenda. Some of the patients are not aware with the medical issue, or they don't understand how severe or what they should be doing. And they're just refusing because you're not really engaging them in their treatment. However, if you try to explore why is your patient declining a medical issue, and you explore the awareness and understanding, and the patient understands and is aware and everything, try to go one step further and explain to your patient the pros and cons of his or her decision. Sometimes patients think twice when they feel that their decision from the medical point of view could impact something else, either their life or someone they care about or whatever. And in the end, if you still don't come to an agreement, then it's absolutely fine for the patients to do what they want, as long as they have capacity, and as long as you have explained everything in details, and as long as you have documented that clearly. But again, it's your responsibility as a physician to try to do what we call safety netting. So it's not, okay, you know what you want, you have capacity, then okay, do what you do, what you need to do, or what you feel that is good for your best interest. For example, if a patient is insisting to leave hospital before finishing a course of antibiotics, which is one of the very common scenarios, try to make life easier and try to involve other specialties so that you could give the patient the maximum benefit, despite you knowing that he is not having the optimum benefit, the optimum treatment. So for example, try to speak to microbiology about a potent, for example, or a choice of oral antibiotic that would have better penetration, for example, or how could we sort out an outpatient appointment that is a little bit more frequent to monitor how the patient is progressing when goes home. So try to involve others and try to do your best in order to achieve or maintain maximum what we could say benefit for your patient, even if he's not having what you feel is the best for him or for her. And finally, if there's any legal issues about, for example, signing an against medical advice form before leaving hospital, that is something that needs to be mentioned as well. So that is about the refusal scenario. Another very common scenario is a break in the system. And break in the system means that there is some kind of mistake or misunderstanding. So initially, this kind of problem sometimes is difficult for candidates to figure out, is that a genuine break in the system? Is that a genuine kind of mistake? Because sometimes patients feel that it is a mistake, but it isn't. So, for example, if a patient receives some bloods that's not theirs, then that's definitely a mistake. It could be a mistake in labeling, could be a mistake in coding, it could be a mistake wherever, but it is a mistake. But sometimes things may happen in hospital, which could be a natural progression of a disease or a complication that could happen. And sometimes these are not mistakes. It could be related to patient circumstances or hospital circumstances, but not necessarily a mistake. So number one, try to figure out if it is a mistake or not. If it's not a mistake, then just clarify that to your patient. But if that turns to be a mistake, then you need to apologize. When you apologize, usually the patients will try to find out where was the problem or who was the main reason for the problem. Please don't point to anyone from your colleagues, because whenever a problem or a mistake or an error happens in hospital, that's always a matter of investigation. And you won't be in the position to blame or defend anyone of your colleagues, even if you feel that it is an obvious mistake done by a doctor or done by a nurse or done by a pharmacist or whatever. So acknowledge the error, acknowledge the mistake, acknowledge the break in the system, apologize, and usually patients accept your apology if things are not massive. And don't point to anyone else. So don't say, it's my colleague's problem, or it's my colleague's error, or the nurse shouldn't have done this or that. So what you could say, well, I'm not in a position to defend or blame any one of my colleagues, but I want to reassure you that we are going to do our best in order to probe this problem and find out what was the main cause and the reason for it happening. Always mention to your patient that we have a robust system to detect the errors that do happen in hospital. And errors happen every day, every minute in hospitals. There are lots of pathways, lots of guidelines, lots of people working in hospitals, very busy environment. So it's very common to have mistakes in hospitals. But it's also important, and it's one of our governance issues, to probe the problems, find the problems, and try to do our best or find out a methodology that we could follow in order for these errors not to happen again. And that's what we call a DATEX, or an incident form. Sometimes patients are not happy with a DATEX or incidents form. They may feel it's not enough, and they may want to raise a formal complaint. If that's what the patient wants, however, we're trying to do all of the previous steps to avoid the last step, number 5. But if that's what the patient wants, so you'll need to be helpful and show the patient how to do that formally. So usually it is about providing a formal complaint to the patient advice and liaison service, and every hospital or every trust has got a specific office or officer for these kind of complaints. So the patient complains in a formal way, and then that is investigated by the relevant department or relevant physician or whatever. So that's the main way that I always find very useful in dealing with breaking the system scenarios. Breaking bad news is one of the very common things that we practice daily in hospitals. It's very difficult when you are meeting someone for the first time and your task is to deliver some kind of bad news. It's not nice. So you don't know anything usually about, you may not know the patient, you may not know the relative that you will speak to, or the wife or the daughter, or you don't know what's going in their own lives. So it's difficult. So breaking bad news means that you literally break the news in bits and don't give it as a one whole straight away. So initially try to find out and explore the main expectations and ideas about the issue that you're going to discuss, or the news that you're going to deliver. And there's always a way about trying to say that you've got a result that is not nice. So for example, if someone has got for example, just as a straightforward one, like a lung cancer, for example, and a biopsy has been done to find out what is going on with the lungs, while the patient perception is that, well, it could be a chest infection. So you could just simply say, well, we don't usually do lung biopsies for straightforward or simple conditions like lung infection. We may do that just to look for something that's much more serious. And don't say we do that to look for cancers. No, that's not the way you break it. The way you break it is that you try to highlight the seriousness of the condition, or how bad is the news that you're going to deliver, so that the patient may even say, well, is it a cancer, doctor? So let him or let them say it in a way or another. Don't say it yourself. Let them say, or they can just say, how serious? So you could say, well, it's pretty much serious. So the next question won't be how serious again. So the next question will be, is it cancer? Or is it life-threatening? You don't need to say yes or no. You can always do like that, do some facial expressions, and then say yes, or do like that, and then no. So you have to play it well. You have to play it well, especially in breaking bad news. And sometimes there are questions that the patient may ask you that are not on your scenario. For example, a patient had a pleural biopsy and it came back showing a malignancy. Okay, so the patient may ask you, are you sure it's my sample? You haven't been provided any information whether you have double-checked. Have you gone through medical history before doing that or not? But usually before we do such scenarios in real life, we do that. So what you could say, well, I would expect, before having such a serious conversation with you today, for all these checks to be done, which is in a way that you're not saying, yes, I've done it, or no, I didn't, but it hasn't been provided in your scenario. So don't fabricate things. Don't say things that did not happen. Don't say, oh yes, of course, I double checked. I checked the label twice and it's definitely you. You didn't do that, okay? And it's not mentioned in your scenario. If it's mentioned, that's something different. But if it isn't mentioned, then try to be smart getting around this. Patients usually react to bad news differently. Some of them may have some kind of denial. Some of them may feel angry. Some of them may feel guilty. But all of these in the end comes to some point of an acceptance, or that would be how your scenario will go. That's the pathway of the scenario, because sometimes the acceptance takes a lot of time to happen in real life. And sometimes it never happens, by the way. But anyway, for the sake of the exam and the scenario, the patient will try to show you that there is some bit of an acceptance, and what are you going to do for me? Or what is there any hope? Avoid any false hope. So if it is a disseminated malignancy, for example, don't say, okay, you'll take chemotherapy and you'll be fine, because that won't happen, and you know that it won't happen. So you could say that we could seek the advice of our experts to see what kind of treatment we could give you so that you won't be feeling any pain, or to control the spread of the disease. Try to be honest and try to say vague terms. Don't say palliative chemotherapy. That means nothing to the patient, and that's full of jargon. Okay, don't say we can do a surgery to cure it if you don't know if it is something curable. If it is something that is vague, just keep it vague. If it's not clear on your scenario, keep it unclear. And you can easily say, we will ask the specialist, we will have another look, we could do more investigations or whatever. But if it's clear, then mention it's clear. If it mentions on your scenario it is terminal malignancy, then you could, or disseminated malignancy, then say, well, I do think that there isn't a cure for that. However, there could be some treatments that we could offer that could make things a little bit easier to avoid any spread of the cancer or the nasty growth. However, it is a highly specialized area, and we need to speak to our oncologist or clinical oncologist, etc., or a Macmillan nurse if things are in late stages. There are several models to follow for breaking bad news. Some of them I mentioned down below, and sympathy and empathy is very important, not just in breaking bad news, but it's in every kind of scenario. And sympathy means that you understand and you appreciate the hardship the patient is going through. Empathy is a higher level in which you are trying to put yourself in your patient's boots, and where you are thinking together how you could deal in such a situation yourself. And that definitely gets your patient on your agenda straight away. So almost always empathetic physicians have their patients on their agenda and are very liked by their patients. That's what I would say. The last scenarios are the difficult ones. So the difficult scenarios could be a difficult person, like an angry person, for example, or one of your colleagues that's doing something inappropriate, like drinking during being on duty. Or it could be a difficult situation, like treatment withdrawals, for example, or do not attempt resuscitations, despite I don't really like saying it's a difficult situation, because it's a daily thing that all doctors do it straight away. Something like organ donation, for example, for someone that has died, or ventilate or not to ventilate, or unfitness for ITU admission. So these are specific scenarios that are dealt with in most communication skills and ethics books and scenarios, and it's pretty much straightforward about the points to discuss and tackle. Or it could be a difficult disease, something like a complicated disease that you may or may not know about. So it could be something like HIV, for example, with lots of issues regarding confidentiality that you need to be aware about. Or it could be something like needle stick injury, which is a difficult situation, a difficult disease. You need to know how to deal with these things. If you know how to deal with it, that's fine. If you don't make up things, but say that you may go and think about it, or read about it, or speak to occupational therapy, you will lose marks, definitely. But that's much better than saying what's not there, definitely. Right, so I think we are nearly passing half of our dedicated time, so let's try and practice some scenarios. Zainab, are you still there?
Yes, I am here.
Okay, great. So I would...
A great introduction.
Thank you so much. So I would like one candidate, a volunteer.
Yes, we have Amir. I think we're starting with Amir.
Okay, fine. That's the scenario. Right, so that's how you find the scenario at the beginning of your station. And these are some demos for scenarios from the MRCP UK.org website. There are around 24 scenarios there, and they are very, very informative. So you could use these scenarios to give you an idea about the most common scenarios that do come in the exam, in addition to any kind of literature you are referring to. So it usually starts with giving you your role. So you're a doctor on the medical ward. So when you introduce yourself, you will introduce yourself. I'm, for example, I'm Mahmoud, one of the doctors on the medical ward. And the problem is dealing with terminal illness. So you will need to figure out where does that lie in our scheme in terms of my ways. So that usually lies in a difficult disease or a difficult situation. And that's the name of your patient. You refer to the patient as Mr. Wallace, okay? And you will speak to a relative, which is Mrs. Wallace, the patient's wife. So take 5 minutes, think about it. You will go for the scenario. Is it Amir?
Yes, it is Amir.
Okay, Amir. So you will go to the scenario when I ask you to do so. And we'll give you something around 10 minutes. Usually, if it is the old PACES, it's 14 minutes, but if it's the new PACES, it's 10 minutes. So I'll put 10 minutes on my stopwatch, but I'll give you 5 minutes first to read about it and to arrange your thoughts. Is that okay?
Fine, thank you.
Great. Afterwards, we'll have an open discussion, and I would expect all of us to be participating so that we'll get the most of it. Okay, Amir, I'm ready when you are.
Can I have like 30 seconds?
Of course, of course.
Okay.
Take your time.
Okay, we can start now.
Okay, great. Are you ready, Zainab?
Yes, I am.
Okay, so let's start. I'm stopwatch starting now.
Okay. Hello.
Hello.
My name is Dr. Amir. I'm one of the doctors here in the medical world. Is it Mrs. Susan Wallace, the wife of Mr. Anthony Wallace?
That's correct.
It is nice to meet you, Mrs. Wallace.
Nice to meet you too.
So, Mrs. Wallace, we are here today to discuss about the condition of your husband. Would that be okay with you?
Please, yes, sir. That's okay.
Yes. And we already granted his permission to talk about his medical condition with you. So before proceeding any further, can I just start by asking you, how much do you know about your husband's condition?
Well, my husband has been diagnosed with lung cancer 2 years ago, and he had an operation to remove part of his lung at that time. And things, to be honest with you, things went very well after the operation. He didn't have any complications. He recovered very well. He went back home early after the operation. So things seem to be very going very well with him. And they remained well. He remained in very good health, reasonably very good health for his age, for about a year and a half.
Okay.
A couple of months ago, things seem to be going downhill with him. He started developing pain in his back. He became quite breathless and generally quite lethargic and tired all the time. So I took him back to hospital, and the doctors did a lot of investigations, a workup on him, and they found that the cancer came back. So at that time, they arranged another session of chemotherapy. To be honest, they arranged a session for chemotherapy and radiotherapy for him. And radiotherapy went very well with him. The back pain was quite relieved after the session, and he responded very, very well to chemotherapy, which I wasn't expecting that, to be honest with you. We weren't expecting that because we always hear bad things about chemotherapy, and with him, he didn't have any issues with it. He developed minimal side effects. So yeah, he responded very well to chemotherapy and radiotherapy. They were quite effective with him. But this good outcome, I would describe it, lasted only for a few weeks. It didn't last longer. So I'm not sure, to be honest. They gave him the chemotherapy, but they didn't tell me what's the outcome of chemotherapy. did this cure the cancer recurrence or not? I haven't heard anything from him, because for the last few appointments he's been going alone to his doctor. I didn't go with him because they were just routine appointments, so I didn't feel the need to be with my husband in his routine checkups. Yeah. That's
Okay.
what happened, yeah, so far.
Okay. Yeah, Mrs. Wells. So do you have an idea what might be the problem this time?
I don't have a clear idea, because over the past week he became quite breathless, quite unusually breathless, and he stopped eating and drinking, which is quite unusual to him. So I brought him to hospital 2 days ago, and I feel he's been deteriorating while he's in hospital. I don't know what's going on. Nobody has explained anything to me. I don't know what doctors are doing to help him. And so the only thing I can see when I come and visit my husband, I'm spending most of my time with him in hospital, that things are getting worse. He's been giving antibiotics, which made no difference to his health, and apart from making him feel sick and vomit, nothing is working at the moment. And I don't feel there's any good effort is being made to make my husband feel better, which I'm not happy with.
So yeah, Mrs. Wallace, I really appreciate all of your concerns, and that's why we are here today to discuss about these concerns, and I will answer most of these questions, of course, by the end of our consultation. So I will talk about why we give him antibiotic and why he's having such these symptoms. But can I ask you one more question, if I may?
Trying to get some answers, so please explain what's going on with my husband.
Definitely, Mrs. Wallace. So can I ask you, what is your expectation of our consultation?
Well, I'm expecting another session of chemotherapy, radiotherapy. I want my husband to get, I feel I can see that he's struggling, so I need the maximum health and medical support you could give him to get him back to what he was a couple of weeks ago before this deterioration, because he responded very well to chemotherapy and radiotherapy last time. And I want that to happen again. I want my husband back with me home.
So, Mrs. Wallace, as you mentioned, your husband, Mr. Wallace, has been admitted 2 days ago with a severe breathlessness. So I'm sorry to tell you that the results of the investigations and all of his tests are not as we expected.
What do you mean by that?
So, Mrs. Wallace, I mean that his cancer has rapidly spread to all of his lungs, and his lungs now has an extensive amount of the cancer.
Well, I know that the cancer came back again, and that's why I'm asking for another session of chemotherapy and radiotherapy, put him on a ventilator to help him breathe, anything necessary to get him back home with me.
So regarding this issue, Mrs. Wallace, the medical team and the management team of his condition, like the cancer team, have discussed his issue. And I'm sorry to tell you that Mr. Wallace is not really in a good shape for another round of chemotherapy. He is too unwell to have another round of chemotherapy.
So why wasn't I told that earlier? Why are you telling me this now?
Because
he's here for 2 days. Why nobody said that? Why you're giving him antibiotics if he's not?
So as I mentioned to you, he was given antibiotic because we were trying to treat the infective part of his condition. We were not sure at that time if the cancer is spread to his lungs and if he has an extensive illness. That's why we give him antibiotic, trying to make him better, and they were in his best interest at the time of admission. But now, with the discussion with the cancer team and with his consultant. We found now that your husband, Mr. Wells, is too unwell to have this chemotherapy. And I'm sorry, I'm really sorry to tell you that he is expected to die in the next 2 to 3 days.
Expected to die?
Mhm.
Is it? Are you seriously saying that? Is he expected to die in a few days?
I'm sorry to tell you that I am serious about his condition, Mrs. Wallace. Do you
So
want
why
me to
can't you give him
explain more
another
about his
therapy
condition?
and radiotherapy? Why can't you give him a stronger antibiotic? Why can't you put him on a ventilator?
Yes, Mrs. Wallace, I totally appreciate your concerns, and your concerns are valid. But let me tell you that sometimes the cancer may be extensive, and the patient may be too unwell to have another round of chemotherapy. And even with the chemotherapy, even with stronger antibiotics, I'm sorry to tell you that Mr. Wallace will not make it up, will not make it with all of these treatments. These treatments will only increase the suffering and only increase his symptoms, and they will not add any benefit to his treatment right now.
So what about putting him on a ventilator? I know ventilators put the lungs at rest until it recovers. Why don't you put him on a ventilator then?
Yes. So, like it is in any, I appreciate your
1 minute
concern, like,
remaining,
but it is like in any, it is like in any type of treatment we give. Every treatment we give, we try to make it for the benefit of the patient. But now with this breathing machine, it will not help him, and he maybe not wake up of this breathing machine. And the management team decided that it is not in his best interest at the moment.
What about doing a lung transplant for him? Will he not get any better with it?
Again, Mrs. Wallace, this is a purely medical decision, and I'm sorry to tell you that your husband is not even a candidate for lung transplant because of his condition, because the cancer has metastasized to his bone, and he will not benefit. And of course, will be the decision of the management team. Are you with me,
my husband
Mrs.
is very important to me. I mean, he's the only one in my life at the moment, and I live my life for my husband. I don't want you to give up on him, please. And I want you to do the maximum you can to help him get home with me. I want him to be home with me. You need to understand how important.
I appreciate. Yes, Mrs. Wells, I appreciate your concern, and I'm really sorry about to break this news to you. And I can't tell you we don't give about our patient, but this is the condition. He is terminal in his condition. And regarding this, with your support at home, we can offer you a social support, and we will offer him the best treatment now to keep him like stable and to keep him without pain and without any suffering in his last days of illness.
Can I have a second opinion? Because I'm not convinced with this, to be honest.
Of course, this is your right, Mrs. Wallace. I will talk to my consultant, and I can arrange a second opinion. But I can tell you this is the decision of the management team, and they agree upon this treatment. But this is your right. We can offer such thing. Is there any other concern, Mrs. Wells?
No, my only concern is that my husband is not receiving the treatment I feel he needs to make him feel better. And I feel the medical team are letting him down. And they are not working hard to make him feel better, and they're not doing their best. They're just giving up on him just because he had a cancer recurrence, which I'm not happy with. And I need a second opinion. And I need someone who is specialized in this field to look at this and escalate.
I appreciate your concern, Mrs. Wallace. I will inform my consultant about this demand. We can arrange a second opinion for you. Of course, that will be arranged in a separate meeting. All right. Mrs. Wallace, can I ask you, is there anyone to take you home? Do you want
No, I don't have anyone
to
take me home. No.
We can arrange that for you, of course. Do you want any support at home? Are you financially supported?
I don't have any financial issues, no.
We can support you with this regard, and I will inform my consultant about this. All right, Mrs. Can I offer you some brochures about what is called the palliative care, which is the care that we just discussed about keeping the patient?
No, thank you. I'll be all right.
About
Thank you. Thank you so much. Right. So take a minute to reflect on the whole conversation.
Okay.
Okay, Amir. Tell me, what did you feel about the conversation?
So it was a difficult discussion because we are breaking the bad news with the patient's wife that her husband is terminal in his last stage of illness and he will expect to die in the next 2 to 3 days. And this is not what the patient's wife was expecting. She was expected could be something can be treated with another round of chemo radiotherapy, and she was insistent about this. And she even considered that we are not giving the treatment. It is like we are giving up on her husband. And I tried my level best to explain that this is the terminal illness.
Was there any kind of surprises or anything that you did not expect that happened during the consultation? In other words, did you have a different scenario for how this conversation could go? And then you found something, a surprise inside?
So to be honest, I was expecting her to be shocked. I was expecting her to be surprised. And I was expecting her to be angry because when we are telling her that she will lose her husband in the next 2 to 3 days and we will not give him the treatment about her chemotherapy, radiotherapy as she was demanded, I was expecting her to react that way, to be honest.
Okay. What is the main ethical or legal issue in this scenario, in your opinion?
So the legal issue here would be the palliative care and end-of-life care, and also confidentiality, because we have the patient's permission to talk with his wife.
Okay.
And regarding the ethical issues would be autonomy. The patient's Mr. Wallace have the right to know about his condition. He still have the capacity, and he can share in the management plan, of course, and make his decision. And the beneficence, of course, the patient's it is we should do what is best for the patient and what is best decided by the medical team, that we should not give him another round of chemotherapy, only the palliative care. And non-maleficence would not offer him intubation, as the patient's wife was insisted upon this. This will not be in his best interest. And justice, of course, he has the right to be treated without any discrimination regarding age or gender or ethnicity.
Okay, that's fine. That's correct. Every scenario will have all the ethical issues, and there's mostly 1 or 2 of the legal issues, which you have mentioned correctly. Okay, apart from this scenario, okay, within this discussion, did you feel, and the same question is for Zainab as a surrogate, did you feel that there's any of the 2 parties having an upper hand in this conversation?
You mean the surrogate and the doctor?
Yes.
And the upper hand in the conversation?
In other words,
I'm not sure I really
in other words,
understand. Okay.
did you feel that the surrogate is demanding, trying to push, trying to blame you,
So
having high
yes,
expectations?
so the surrogate, after knowing that we are not going to give him another round of chemo or radio, she was insisting on the part that this is a malpractice and we are not give him the best treatment is available. That's why she was asking for a second opinion. She was a little bit pushy on that side, but it is expected. Actually, it is expected. The patient's relative, because they are on the edge of losing their loved ones, and as a medical professional, we have our ways to deal with this manner.
How do you
but
deal
again,
with this manner?
yes, so
If you
we
have someone
try.
with very high expectations, how to bring him down?
Okay, so first of all, we will try to be empathetic and sympathetic as much as possible, and we try to explain the things in very layman
I
terms.
don't want you to answer me the answers that you will mention in the exam.
All right.
But we're trying to deal with a human being. Okay. How could you drag these expectations to the ground? How could you try and bring these expectations, which are not realistic, to reality?
By showing how of these expectations can be non-beneficial for her husband at the moment, and how these can be really bad for his condition at the moment, like with the breathing.
Don't do this. See, I'm telling you, try not to do this. So this will definitely cause you to go in conflict with the surrogate or with the relative. Do you want me to tell you how to deal with that?
Of course.
Explore chemotherapy and radiotherapy and surgery with the patient. So ask her specifically, how did he cope with the operation in terms of daily activities, in terms of shortness of breath? How did he deal with chemotherapy? Did he have any problems with chemotherapy? Did you feel that his body is getting weaker with chemotherapy? Did radiotherapy cause him any problems, any hair loss, any problem with bowels, anything like that? Try to focus on the side effects of chemotherapy and radiotherapy and the fact that he's getting frailer and frailer. So the patient, and she won't lie, she won't deny, she will tell you the truth. But the issue is she's having very high expectations for him to live, regardless the condition that he will live with. It's very challenging to tell someone that he is not a candidate for something. So if for example, she asks you about a lung transplant and you told her, well, he won't be a candidate for a lung transplant. It's challenging. It's very challenging. It puts the patient or the relative in a situation in which why he's not a candidate, why they don't want to offer him this kind of treatment. Put it the other way. So put it that, well, I think that his weak body at the moment won't cope a major operation like lung transplant. And if we think about doing that, the main risk is that he won't live after this operation. That's different. Okay, it is the same meaning, but it's different words. And that's the whole issue about communication. So for example, don't say terminal. Terminal cancer, that just gives the impression it's correct. It's not a false thing to say. But if you say, well, the cancer is in an advanced stage, that's different. If we say that we're giving treatment to try to minimize his symptoms, or decreases suffering. That's pretty much the meaning of palliative. Try as well to magnify the treatment that he received. Well, actually, this patient specifically had surgery, chemo, radio, he had everything. But despite all of that, his cancer recurred after 6 months. And unfortunately, it has spread to the lungs and bones. Were you aware with this kind of information? Most of the time, she will be aware. And then she will feel, okay, it sounds like, okay, where are we going from here? And don't try as much as you can, don't put fixed days. I know in the scenario, it's telling you 2 to 3 days. Don't say 2 to 3, say soon, okay? So say a couple of days, say less than a week. And before saying such kind of terrible news, try before saying it, making sure that you have done all kinds of preparation for that. What we say in Arabic, مهد للموضوع. مهد, and the patient is going to die. He's been very unwell the last month. Even with his shortness of breath, we thought it could be an infection. But it seems that we are not winning. We are not winning. These terms make all the difference. And instead of this patient being demanding, she will look at you as a physician seeking hope or seeking, okay, where do we do from here? After showing this kind of situation, tell her, okay, so what do you think at the moment? So what do you think would be the next step? It seems that we're not winning and he won't have much to live. The nice way of saying things in terms of that you want to deviate to the palliative route, that you will say, it seems like nature will be taking its course. And if that is happening anyway, we need to do it in the proper way to make sure that he doesn't suffer anymore and he will be comfortable the remaining time. What do you think?
Of course, this is much better, of course, with the wording and the way you pick these words to communicate with her. I think this is much better.
So this was a difficult one because you were having a mindset of trying to explain that it is the end, but you found that your surrogate is seeking for more. And she's coming from a different expectation and she's not being realistic. And furthermore, she's asking for a second opinion. That's fine, second opinion, that's more than, it's her right to seek for second opinion. And when she says second opinion, then most probably she wants to seek the advice of another oncology team in a different trust, for example, or something like that, which is absolutely fine. But again, involve the palliative team and involve the oncologist. It's not your call, by the way. I mean, the patient is on your ward. You are working on the ward, but it's mainly an oncology issue. So having a specialist will be very, very helpful. Remember that you're not alone. So you could say, for example, that's fine. We can have, or I would do my best to arrange an appointment for you with one of the specialists or a specialist nurse, and I will get in contact with the nurse in charge today to see how we could sort that out in the nearest opportunity. But usually when it's about 2 to 3 days in terms of that the patient is dying, it's more likely that we need to speak to the palliative team rather than an oncologist, because oncologists won't add anything now. And if you ask me if this patient wanted a second opinion, I'll tell her that of course it's her right to seek a second opinion. However, I think at the moment we need to focus on other things that may be related to your husband's comfort rather than trying to push hard with any kind of treatment, which may be futile because we've tried all of that before. But again, these words are very difficult. Futile, for example, is a very, very difficult word, very hard word on the ears. But yes, it was difficult. But it's always about how you deal with things and how you pick up the nature of the surrogate and where the surrogate wants to take you, and trying to pull the surrogate back to your agenda. Okay. Zainab, do you have any comments?
Yes, thank you. Very nice feedback. I just want to add something. Thank you, Amir. I mean, a very empathetic approach as usual. I mean, I know in the scenario it says you have the patient's permission to discuss the case, but just take it as a habit. Make sure you ask, are you the next of kin? You have lasting power of attorney.
I did write that as well. Yes. So so that needs to be mentioned.
Yes.
That definitely needs to be mentioned always.
Yeah, always, because you need to make sure that you are speaking to the right person. Just in case this patient survives and you spoke to the wrong person, you'll be in trouble.
True. So yes.
Can I add something?
Yes,
here?
of course.
Yes. So about on this part with the next of kin and the lasting power of attorney, as I've been told and I've been mentored by some mentors, that when the scenario tells us that we have the patient's permission to talk about his condition with that relative. So at this on this occasion, we will not be asking the relative, are you the next of kin? Because the patient already have given his permission to talk to that person, whether he's the next of kin or not, because the patient still have the capacity and he give us this permission. But when the patient is losing his capacity and he's unaware of things, we maybe can ask this, are you the next of kin to that person? And another thing on the part of lasting power of attorney or advance directive, this is also, you correct me, I also have been mentored about this. When the patient has the capacity, we should not discuss this with his relative. Is your wife or is your husband has the lasting power of attorney or advance directive, because he still has the capacity and we can discuss this with him. But when he lost his capacity, we can't mention this to the relative.
Unless the patient asks you for that. That's correct.
I kind of still, I mean, this is what we do in real life. Even when we know that the patient has given the lasting power of attorney to someone. Usually in real life, even if they have capacity, they do give lasting power of attorney because they feel too weak to deal, or too weak or too ill to deal with these kind of things like financial issues or health related issues. And it's just, even I know in the scenario says the patient has granted the permission. It's just like as a habit, you're showing the examiner that you know the ethical approach to such cases. Even if you know there is a permission, you need to, I mean, that's how I approach it personally. I mean, different people approach it in different ways.
Let me just take it easy on you both, because these specific issues are not massive in overseas exams.
Yes.
So if the patient gives you a consent to speak to someone, even if it's not next of kin, just confirm the bit of information that's mentioned already, and that's fine. If you want to ask, are you next of kin, the surrogate may tell you, well, I'm not next of kin, but I'm his daughter. That means that you will
so this is my point.
That you will still speak to her, but
yes,
you are showing to the examiner that you are aware. I know what is the difference, what is a next of kin, and I could speak to someone else, not the next of kin, as long as I had the permission. Regarding the advance directive, and because advance directive could be related to finance or medical issues or health issues, that's very difficult. As long as the patient is having capacity and he's speaking with you, that's fine, no problem. But you could still discuss with the person that has got the power of attorney. You could still do that. So if someone has got a power of attorney, for example, if it is a son, and the patient has got, for example, advanced Parkinson's or dementia or whatever, and you feel that you're speaking to the patient now, and he is having capacity now, it's fine. You can speak to the patient, and you can still speak to the person that has got the power of attorney. It's absolutely fine. Because sometimes patients do have fluctuation in terms of their capacity. But again, that won't be discussed in an exam. That won't be the issue of an exam at all. Because capacity assessment, there are many ways of doing it. There is a formal capacity assessment versus a non-formal capacity assessment, a full capacity assessment, and a minimized capacity assessment. So, so just the main things, and both should be correct. Rand raising a hand.
Hello, Doctor. Thank you for the session. So yes, my writing in the chat was she was demanding for another session of chemotherapy and also lung transplantation. So in that way, we can ask her, do you have the lasting power of attorney, or did your husband make any wishes regarding the future treatment? That's why maybe
you're taking it a step, 2 or 3 steps further. So that could be much easier, just showing her that his body won't tolerate. So
yes,
she's
even
not,
after that, if she's not accepting that, then we can maybe.
I'll tell you something, Rand. She's not really demanding. I mean, she's got a hope.
Yeah.
She is exploring in the way that she is demanding, because she's refusing that she's declining the idea that her husband will leave her. So it's not about I want him to have chemotherapy. That won't happen. That won't happen. And it's not her decision. And it's even not the patient's decision, because as I mentioned, the patient could decline treatment, but couldn't ask for it. The patient could ask why I couldn't have it, and then you could explain. Okay, try not to take the issue to another step or another complicated step, because if you show her or ask her, how do you feel that he was getting weak after chemotherapy? At the moment, how much is he doing for himself? How was his appetite? Is he able to do his daily activities? All of that will tell you that the patient won't be even fit for another round of antibiotics. Do you know what I mean?
Yes, I see your point. Yeah.
So, and again, patients or whoever has got power of attorney haven't got the right to ask for specific form of treatment. They could decline treatment, but they don't have the right to ask for treatment, as long as it's not appropriate from the medical point of view and you have your justification. If you want to ask, did he show any wishes? That's absolutely fine. But that is another thing that you may not have time for that. But it's correct, because we usually in real life, these discussions don't take 10 minutes. It may take 30 minutes or even 45 minutes, or maybe the whole afternoon.
Yes, so my point is that when she was requesting for chemo and transplantation, it is worth to know what the patient maybe had discussion, what he wants to be done for him. So this will help in persuading her.
Yes, so that could be another step if you try to show her how frail he is and she's still not accepting. Or you could start from the beginning to tell her, well, okay, fine. Did Mr. Wallace himself show any wishes or any expressions about what would be the next step in his management?
Yeah.
Okay.
Yes.
So that's the difficulty about dealing with human beings.
Yes.
Clearly, she was a patient who was living in denial, and she needed someone
absolutely,
to
absolutely.
explain things
and
to her.
As I mentioned to Amir, it's about you picking up quickly that the patient is not on your agenda. Number one, she's got high expectations, and I need to drag these expectations down to reality. That's the main thing. Let's go to the next scenario, otherwise we'll run out of time. It's very interesting.
I think Rand is our next candidate.
Let's go.
Yes.
Is my screen sharing?
Yes, yes. So this is Miss Fadhila Kahar, isn't it? This station. Yeah. Okay.
So you are the doctor on the ward, and you'll be discussing valid complaints from a patient with unresolved acute pyelonephritis who wishes to discharge herself. So where does that fall in our scheme, in my way?
It's
mainly
convincing a patient regarding some staying in the hospital. I don't know which category do you put it.
It's a refusal.
Yes,
so,
refusal.
So
refusal to stay in hospital.
Yeah. Usually the scenarios are mix of things. So there is a bit of explaining with a bit of refusal. There could be a little bit of break in the system. There may be a little bit of bad news. Sometimes it's a difficult situation. So it's a mix of everything. But as long as you know how to deal with every single thing, you won't find a problem.
Okay, so I will have 5 minutes.
I will give you.
Okay, thank you.
5 minutes.
أقول شو أسوي راح أروح أسود.
Okay, Rand, can we start?
Yes.
Yeah, let's go. Right,
Okay.
so 10 minutes starting now.
Good evening.
Hi, good evening.
I am Dr. Al-Radi, one of the doctor here in the ward. Are you Miss Fadhila Kahar, 23 years of age?
Yes, that's correct.
Nice to meet you, Miss Kahar.
Nice to meet you too.
Ms. Kahar, I am here to discuss your condition and possibly help you. And will that be all right with you?
Please, because I need that help.
Okay. So how are you feeling now, Ms. Kahar?
I feel rubbish, to be honest. I don't feel well and I need to go home now.
Okay, I'm really sorry for what you have been experiencing, and I will help you with this regard. So, Ms. Kahar, I know that you are in a difficult position, but are you able to tell me what exactly happened with you?
Well, the whole situation, it's just the whole situation is not good, and I don't feel I've been managed well. 2 days ago, I came to hospital because I hate hospital. Just to start with, I hate hospitals.
Yeah.
I suffer from recurrent urine infection, which I manage at home, and I am fine with that. But recently, I just fell unwell. I started having pain in my loin, high temperature, didn't eat or drink anything. So my husband said, you should go to hospital. Although I said, no, I don't want to because I hate hospital. He said, you should go there because you don't look well. So I came. But I feel I haven't been managed well. I feel I haven't really received what I was expecting. For example, yesterday I was supposed to have a scan for my kidneys.
Yes.
And I don't know, I couldn't have the scan only because I went to the toilet before the scan. And it turned out when I went to the ultrasound that the sonographer started blaming me that I should have a full bladder and why I have emptied my bladder.
Okay.
Which wasn't really nice because nobody told me that I shouldn't go to the toilet before the scan.
Okay.
No communication, no one is telling me anything. And on top of that, I feel that today I'm supposed to have another scan and I'm really desperate. I need to go to the toilet because I'm not comfortable.
All right.
Are getting delayed and I don't feel the whole situation is worth it.
Yeah.
On top of that, I'm in a ward with other sick patients who are confused and old, and someone's died the other day next to my bed, and I can't sleep well, and I want to go home. I feel I will be better if I go home. It's only an antibiotic. I can take a tablet and I can take it at home.
Okay, I really understand your concerns and worries, Ms. Kahar, and I'm sorry for what you have been through. And it's really good that you came to the hospital to check for yourself after you are experiencing these symptoms. So I wanted to know why you feel you weren't managed well.
No one is talking to me. No one is telling me anything. I'm just sitting there here. They just give me whatever they are giving me through the vein. And that's no one is telling me anything. And when I go and have a scan, which doesn't go, which was declined, they start blaming me for just going to the toilet because no one has told me anything.
All right. So I am here to answer all your questions and explain to you what happened and how we can move from there. Okay.
Well, to be honest, I don't want to hear anything. I want to go home. I don't.
Okay. Okay, Miss Kahar, and this is another thing I would like to learn from you. Is there any particular reason of why you want to go home?
As I said, I've just explained it to you. No one is telling me anything.
So basically because of the hospital situation, you don't like staying in hospital.
I hate hospitals.
Okay.
I'm here and no one is looking after me. No one is telling me anything. And it's quite noisy. I can't sleep. I feel comfortable. I feel better if I go home and have some rest and good sleep.
Okay. I really understand you, Ms. Kahar. So let me explain to you about your condition, if that's all right with you. Then I will guide you accordingly about your staying here. So basically, you are having an infection, a bug infection of your kidney. And I can understand that this is not the first time that is happening to you.
No, I mean, I've never been to hospital before, as I said. Usually
Okay.
I take tablets and get better, and I'm sure if I take tablets and go home, I'll be some painkillers, I'll be fine.
Yeah, so unfortunately, you are still having a raised temperature, and also you are experiencing pain and also having nausea and vomiting, as the nurse told me. So currently, we are giving you fluids through your blood vessels and also giving you painkillers for that. So we need you at the moment to stay a little bit in the hospital until you are stable and safe to go home.
Well, I can't take tablets and go home. I can still take anti-sickness tablets and painkillers and go home.
Unfortunately, those tablets, I'm afraid they are not effective at this point. You need these fluids and medications to be given through your blood channels. And at the same time, you are still vomiting and experiencing nausea. So it's risky for you to go home. You might need more fluid. So that's why you need to stay. And another reason is, I'm sorry for the miscommunication that happened yesterday with your ultrasound scan. Basically, for ultrasound scan, you need to have a full bladder, which is with, with water and urine. It will help better to visualize what is causing your infection, because this is not the first time you are having this infection, and we are trying to get to the bottom of why it's happening to you. That's why ultrasound at this point is really important.
Well, I can have the scan and go home, and if I come unwell, I can come back to hospital to get more.
Yes, I really understand. I know you don't like hospital. I will see if we can change the room for you so you can have a more comfortable stay here. But as I said, it's really risky for you to go home. This infection can...
What would happen to me if I go home?
Yes, so this infection can spread to your blood and can go to like other organs as well. And we need to know why you are having this repeated infection. If we don't get to the bottom of this, you might need to come here again. It can happen to you again, and it will affect you so much. I mean, you need to again be admitted to hospital and go through this another drugs and fluids through your blood channels. So we need to find what is causing you so we can prevent it from happening again. Does this sound like a plan for you?
So will this infection be cured by the antibiotics you're giving me at the moment?
Yes, in addition to the antibiotics, we need to know what is causing this infection. So after we learn that from the ultrasound scan, we can manage it more appropriately. But for now, you need this fluid and the antibiotics and the painkillers.
To be honest, I know the nurses are busy. I mean, I know I'm blaming you guys. I'm blaming the doctors and everyone, but I know everyone is busy and they will not be able to look after me. And honestly, I can't sleep. It's too noisy in the ward, and I need somewhere quiet. I feel...
Yes, I'm really sorry for what you have been experiencing. I will make sure you have a nurse to monitor you and stay with you regularly, and also we will see if we can shift you to another ward. Does this sound all right for you?
Well, another ward will be the same problem, just the noise of people around me. If I stay in hospital, I think I would stay if I have a single room on my own, away from confused old patients.
I will discuss this with my consultant and get back to you with an answer. But in the meantime, I'll make sure that you are comfortable, and I will have a nurse with you to monitor you and answer all your concerns and wishes.
So how do I avoid getting this again? How do I avoid getting this infection again to avoid coming to hospitals?
Yes, as I mentioned to you, you need to stay with us first. We need to figure out what is causing this infection, because this is just symptoms now. We need to know why it's happening to you. So when we find out by the ultrasonography, the scan, which is scheduled, yes, which is scheduled today. Then we can guide you further. Why is happening and how can we prevent it? And what kind of treatment we'll be providing.
Okay,
does this
fine. As long as I will get my own room, then I'll stay.
Yes, as I mentioned to you, I will discuss this with the consultant and get back to you with an answer. So, Miss Kahar, can I ask you questions aside from that?
Yeah, you can ask whatever you like.
What do you do for a living?
Well, I'm a PhD student at the moment.
Okay, and this how these infections, like especially it's not happening for you for the first time, how it affected your life and your student life, I mean.
So time is up.
Okay.
Okay, Rand, take a minute to reflect on this conversation. Okay.
Yes.
Rand, tell me what did you find any surprises with your surrogate? Did you have a scenario in your mind and found something different in the station?
Not really. It's as I expected. The patient wants to go home and she doesn't like staying in hospital. That was her main reason for not wanting to stay in hospital. And I was trying to persuade her and that I will make her stay more comfortable.
What's the main reason for her not to stay in hospital?
She doesn't like coming to hospitals and she doesn't want to be around patients and noise. So that was her main reason.
In what way? So what was the problem with the patients?
Because people were getting sick and someone died beside her and there was a lot of noise and that she felt she wasn't being looked after by the nurses. And there was miscommunication regarding her ultrasound scan. That's why she refuses to stay here. She was feeling that she's not being properly cared for.
Good. And did the patient understand how serious is the condition?
Yes, so I told her about the risks that are associated with not treating this infection, and that
what
can
is
cause
the risk of not treating this infection?
It can lead to sepsis, it can lead to abscess, and there could be another serious
sepsis. And what happens with sepsis?
I told her that it can transmit to her blood and other organs. So I told her.
And then
death.
Yes.
But I didn't tell her
not
this.
death, but you can say that could be severe sepsis, septic shock, ICU admission. And possibly if that's not treated well, then there could be a problem with the kidney.
Yes.
Maybe acute kidney injury, maybe needing dialysis.
Yes. And I was telling her that you will experience more hospital admissions, more pain, and again, it will affect your life further.
In addition to that, she's having sickness, she's vomiting.
Yes.
So it's less likely that the medication will stay in her tummy.
Yes.
So if she goes home, she won't be taking any medication.
Yeah, so she expressed that the tablet might help her. I said the tablet wouldn't be effective for her. We need to give you medication through your blood vessel.
Why not effective? Because it's not absorbed, because she's vomiting.
Yes.
So even if she takes the anti-sickness tablets, that won't go to her bloodstream, and that's why we need to give things intravenously.
Yes, that is I didn't clarify for her at this point.
Okay, let me take you somewhere else.
Yes.
So you have explained all of that and the patient still wants to go home.
I will, after everything, she can sign the documents that she wants to be discharged against the medical advice.
Okay, that's the last thing we will mention. What
Yes.
are we going to do before that?
I'm sorry, we will mention before what?
How are we going to make her safe at home? Is there any possibility that she could take the intravenous antibiotics at home?
Maybe yes, she can, but we need her to stay for the ultrasonography scan as well to know why she's having this repeated pyelonephritis.
She wants to go now, and she will have the ultrasound scan as an outpatient.
I don't think it's good for her to go because
we all agree. I mean,
yes.
Now we are coming to a situation in which she will do what she wants, but we are trying to minimize the risks. So is there any possibility, for example, for her to have the antibiotics at home? The intravenous antibiotics at home?
I don't have an answer for this, unfortunately.
Okay. If there is a possibility, is there someone that we need to speak to in order to make sure that she gets the proper antibiotic? Suitable one
maybe specialized nurse.
Yes.
I'm not sure.
Or a microbiologist?
Yes, maybe. Yeah.
Yeah, that's fine.
Yes.
So Zainab.
I just want to mention my ethical and legal issues.
Okay.
Okay, so the autonomy, she has the right to know about her condition and the risk associated with her condition if not properly treated and if she's discharged. And also the beneficence is that we are giving her fluids and painkillers, and we are arranging for an ultrasonography for her to find the causes. And the non-maleficence is by not sending her home. And just as she has the right to be treated equally with like other patients, regardless of her sex, gender, race, and financial background, and so on.
You mentioned something about moving her to another ward. How easy or how difficult is that?
Yes, it can be challenging. That's why I offered to discuss this with my consultant first and see the possibility to make her stay more comfortable at the hospital.
If I'm your consultant, I'll be more than happy if she goes to another ward.
Okay.
So whom is the relevant person that you should speak to?
I'm not sure really. It's in the UK things. I'm not sure with whom I should.
It's a bed manager.
Ward manager, maybe.
Ward manager or bed manager, any kind of manager that looks after this issue.
Yes.
And one other thing, she wants to stay in a side room to be away from noise and to sleep better, which is absolutely fine. But is that the indication of side rooms?
No. No, that is on her. I mean, if she wants to pay for that privately, she can, but it's not her right to request a separate room. So, well,
let's don't speak about private practice, but the issue is the way it works in the UK. No, I mean, I don't feel that this would be a main issue, but just for you to know that. There isn't much side rooms. So side room is something like a very, very, very precious thing. And we usually keep it for patients who are indicated to be isolated. So, so if she tries to push in this way and you try to tell her that side room is not, it may not be available because there is a priority depending on medical condition, and some patients may have a medical indication to have a side room rather than your indication.
Yeah.
That doesn't mean that your indication is not important to us. It is important, but it's all about priorities. That makes that you are trying to
disregard her feelings.
It's about her consciousness and about how she feels about others. You know,
okay,
we could say you're not dealing with a law, but you're dealing with روح القانون.
Yes,
you know
I wasn't sure about this. That's why I thought I will discuss this with my consultant, because I wasn't sure about the private room thing.
Yeah, but yes, you've done the refusal thing right, in which you try to explore to find out why. You checked her understanding about the condition. You did need to highlight the pros and cons, and to magnify the cons that she may, if she doesn't receive the appropriate treatment, she may get a septic shock at home. She will come sicker. She may need ITU admission. She may lose some of her kidney function. Some of other organs may fail. Try to threaten her in a nice way.
Yeah.
So that she'll say, okay, fine. How long should I stay in hospital? 2 days, 3 days? So we will try to do our best. Okay, this scan, what can I do?
We will say
Yes,
until
you
your
can speak to radiology.
Until your situation is stable and until we make sure you are safe to go home.
Absolutely, absolutely, because safety always comes first. But again, if she insists to do what is not safe, then ensure safety netting. So speaking to microbiology, speaking to sometimes there's something called hospital at home services, or OPAT, which means that some patients may receive intravenous antibiotics at home by a specialist service and a specialist nurse, and that could happen, but sometimes not all antibiotics could work for that. So for example, if it is something like an antibiotic that's given once daily or twice daily, that could work. Some other antibiotics.
Disease monitoring and blood level, yes.
Exactly. Zainab, do we have more time, or we ran out of time?
We're 8 minutes past the time.
We're 8 minutes past. Okay, fine. There was another case, but unfortunately we don't have any more time to discuss it. It was very enjoyable for me to be with you today.
I could just elaborate something on that case. It's an approach I've seen. Dr. Wathiq is one of the attendees. He follows it. When the patient is refusing or insisting or denying treatment, you just need to explain to the patient that it's all about you. We're here trying to help you. We're not against you. We are with you.
Exactly.
So you need to show the patient that you are there for them, not just doing your job and leaving at 5 o'clock in the afternoon.
Of course. Of course. Yeah. Of course.
Maybe you just, if you could just give them, I know time has passed, if you just give them a quick tip how to approach someone like a medical error, the duty of candor, and then we can end with that, if that's okay.
One last thing I want to mention as well for you guys. You will have a 10-minute for evaluation. Try to use all your skills, including your acting skills. Okay, مثلوا. So if someone is telling you something that is bad, or he's not feeling comfortable with, then oh dear, that must be very difficult. And are you managing? How did you cope? For example, the ultrasound thingy that happened, and the ultrasonographist was a little bit rude. Oh, shame. That must have been difficult. And try always to do verbal and non-verbal cues, not just sitting like that. Just move forward and backwards, and do some grimace. Happy, sad. مثلوا. It's important.
Thank you. Thank you. It's all about showing like body language as well as.
Absolutely. Body language is very important.
I'm sorry, I just have one quick question.
Yeah.
So the legal issue here would be the discharge letter, what they call it, in if she doesn't accept.
It's a discharge against medical advice.
Okay, it's called like that?
Yes.
Okay.
DAM.
Thank you. Thank you so much for the session. We learned a lot.
We're not punishing patients if they self-discharge. You do your best to help.
Yes.
Thank you so much, Dr. Montasser. Really, really appreciate your time and help in making this session happen. And you gave us precious advices, and hopefully our candidates will use them all to help them pass the exam, and even use them in their real life. It doesn't have to be in the exam. Like precious tips. Thank you so much. Really appreciate it.
All the best, and I'm happy for you to share my email address with any one of our candidates. And all the best.
Thank you so much. Thank you.
If you excuse me, Zainab, Thank you very much, Dr. Mahmoud. Really, it was very interesting, very informative, and very useful session. I enjoyed it very much, and it was giving very important messages to the attendee. Thank you for your effort. Great thanks to Zainab. She was behind this idea, and she will organize everything for these sessions and communication with you and other colleagues who presented the session for the last 2 or 3 weeks. And I hope our candidate will get benefit to start in the mock exam a few days later on, and later on in the real exam where the Federation team will come to Iraq to check what's on the Pathfinder. Thank you very much. I think this is the last course or the last session, Zainab. And we hope that our candidate and attendee get much of your experience and your comments and your advice, and great thanks to you all.
Thank you so much. Thank you, Dr. Montasser.
Thank you so much.
Thank you, everyone. Thank you all, Canada, and wish you all the best.
Bye-bye.
Thank you.
Have a good night. Thank you.
Bye-bye. Good night.